Hello and welcome everyone. Today we'll be discussing how to use toxidromes in the ICU. Managing poisoned patients is challenging due to delayed toxicological confirmation. Many places do not even have these diagnostic tests where you can find out what poison has been consumed. The toxidrome based approach helps identify poisoning based on clinical signs and the symptoms. It groups toxins with similar effects, enabling early diagnosis and a treatment. It is useful for quick decision making, especially when a history is unavailable, which is usually the case. The strength is it is helping in rapid diagnosis, early treatment, and avoids unnecessary tests. And the limitations being some poisons have a mixed or unclear symptoms, which can make very difficult to localize on them. Now, the usefulness of toxidrome in the ICU is in rapid identification. It helps the clinician determine the class of the toxicant. Immediate treatment needs to be given, which enables early administration of antidotes wherever it is available. Clinical monitoring, it guides the continuous observation and supportive care in the poisoned patients, helps recognize initial signs of poisoning in exposed but asymptomatic patients. So there is a stepwise approach to this toxidrome. First is assess the vital signs. In this, measure the temperature, respiratory rate, heart rate, and blood pressure. This is extremely important. And greater deviation from the normal value indicates more severe toxicity. The example here is you can see high fever and rapid heart rate. It is a possible stimulant or anticholinergic poisoning. So these are some of the ways by which you can point towards a particular poison. The next is perform a detailed physical examination. In this, do a neurological test, which is the most important and the first one that should be done. That is pupil size. Check if it is pinpoint. If it is pinpoint, it points towards the opioid. If it is dilated, then it points towards stimulants or anticholinergics. Abnormal movements, look for tremors, seizures, rigidity, which are again associated with specific toxins. Muscle tone and reflexes are increased with stimulants and decreased with sedatives. Mental status, whether the patient is agitated or in coma, which can give you an indicator. Next is extraneurological examination. In this, check for the respiratory thing. See if it is slow breathing, it will point towards opioids, fast breathing to salicylates. GI tract, vomiting, diarrhea, again suggests certain toxins like OP poisoning. Urinary, check whether it is retention or incontinence. And skin, whether it is sweaty or dry, again completely different poisons. So after you have done this physical examination and vital noting, next you go on to the bedside clinical tests, and also we can learn what are the limitation of the toxidromes. So the first test that we need to do is the ECG. Always perform to detect arrhythmias and conduction abnormalities, as in, for example, tricyclic antidepressants, you will find a prolonged QRS. Capillary glucose, again an important point, check in any patients with impaired consciousness to rule out hypoglycemia. As a matter of fact, it should be checked in all unconscious patients. ABG again gives us very vital information regarding the toxin that could be present. Again, next is we try to go into the toxidrome proper, how to interpret it. Toxidromes are not really absolute, they're often assessed as present or absent. But poisoning is a dynamic process which is evolving. The poison is acting and the patient is reacting to the poison, so it's a dynamic process. Sensitivity and specificity are imperfect. Some toxidromes may be incomplete, or there can be overlap also between the various toxidromes. So making the diagnosis is always not very easy. It can be tricky as well. So challenges in identifying the toxidrome is very important. The problem is at times there are mixed ingestions. This can cause a real confusion for us. So the patient may consume multiple substances like with opposing effects. Like for example, speedball, it is a mixture of sympathomimetics and opioids. So it's a stimulant and depressant. So the which symptom is going to come out, it is very difficult to say. Now, some drugs have different effects at different stages, like phencyclidine starts as a sedative and later has a symptomatic toxidrome. So, these things must be kept in mind. There is also something called overlapping drug effect. That is, the tricyclic antidepressant have both anticholinergic as well as sodium channel blocker toxidromes. Like synthetic drugs like amphetamine and synthetic cannabinoids may have absolutely unpredictable effects as well. So we must keep in mind these things, that it is not always that a single drug will fit with a particular toxidrome. It can have presentation as two toxidromes as well. Withdrawal symptoms can resemble poisoning. Sedative withdrawal mimics symptomatic toxicity. Opioid withdrawal looks like poisoning but has a completely different management. Serotonin withdrawal can be mistaken for toxicity but differs in the clinical context, obviously. Now, we face certain challenges specific to the ICU. That is, the neurological assessment becomes very difficult in sedated patients or those who have already intubated and probably even on neuromuscular blockers. So, medications used in ICU can mimic toxidrome findings because of the sedatives and the painkillers that we use. So, let's analyze and see these various toxidromes. Coming to first to the classic toxidrome, the definition here is group of symptoms caused by toxins affecting similar type of receptors. The usefulness lies in helps in rapidly identifying the toxicants and guide the treatment before we get a toxicology report. Now, the first toxidrome is the sedative hypnotic and the opioid one. Here you have a depressed mental status, so they are depressants. You have sedatives, hypnotics. You have no abnormal uh, findings in the vital signs mostly. Complications can be coma related, like aspiration, airway obstruction. These can cause the breathing problem and other symptoms. Opioids are can cause all this. So the key sign here is a coma with a pinpoint pupil and slow breathing. So this is a classic of what is called an opioid toxicrome. Complication of the hypoventilation can be the respiratory failure. Next is anticholinergic versus sympathomimetic. So the total similar type of things. So the common features that you're going to get is tachycardia, hypothermia, mydriasis, agitation, seizures. Now in anticholinergic, that is in atropine, scopolamine and TCAs, the key sign is a non-reactive dilated pupil, dry skin, urinary retention and delirium. Complications being, it can worsen in the elderly. TCA can also cause sodium channel blockade, if you can remember. Sympathomimetics, however, that is the amphetamine, cocaine, and the MAO inhibitors. The key sign here is a reactive pupil. There is sweating, not dry skin, severe tachycardia, and hypertension. So the cardiac effects are kind of more. The complication is the cardiovascular risk of these type of arrhythmias and severe hyperthermia. Next is serotonin versus neuroleptic malignant syndrome. Again, a very conflicting kind of thing. The common features here are agitation, hyperthermia, muscle rigidity, seizures. In serotonin syndrome caused by the SSRIs, MDMA, MAO inhibitors, here you can have hyperreflexia, clonus, ocular clonus, tremors. It has a rapid onset within hours, and complication is severe hypothermia, up more than 42 degrees centigrade, rhabdomyolysis, DIC, and shock. In the neuroleptic malignant syndrome, which can be caused by the antipsychotics and dopamine withdrawal, in that the key sign is a lead pipe muscle rigidity, delirium, and slow progression. There is no clonus or hyperreflexia. And the gradual onset, it has a more prolonged onset than sudden onset like the serotonin. The complication here is that because of the severe rigidity, you will have rhabdomyolysis and hyperthermia. Now, next is the cholinergic toxidrome, that is the OP poisoning that we commonly see. The mnemonic is dumbbells, diarrhea, urination, meiosis, bradycardia, emesis, lacrimation, and salivation. More or less every secretion is going on increasing. Now, the key signs are the muscarinic effects, that is meiosis, bronchospasm, and the bradycardia. Nicotinic effects are the muscle fasciculation, weakness, and hypertension. CNS effect is seizure and confusion. Complication is the respiratory failure due to the muscle paralysis as well as the increased secretion, where the patient is said to drown in its own secretions. Extended toxidromes are also present. The definition here is a more complex toxicological pattern involving molecular interaction beyond the receptors. And in this, you can have the sodium channel blockade seen in TCA, and the key sign here is ECG changes, white QRS, arrhythmias, seizures, respiratory distress, and complications like sudden cardiac arrest and refractory shock. So this is the toxidrome that you can use in your ICUs. You start with the one, that is the vital signs, as we have already noted: body temperature, respiratory rate, heart rate, and blood pressure. Next, you do a clinical examination, which includes the neurological and the extraneurological. And finally, you have some paraclinical tests like the ECG, glucose, and the blood gas. Combining the three, and including the pathophysiology that you know of the possible mechanisms of action of the various toxidromes, you can correlate the vital parameters and the clinical examination, and then find out the most specific antidote that you can give. So you can use this chart in your ICUs on the emergencies. Thank you for your patience.